Thank you, Beth. It's a pleasure to be here, and it's a pleasure to talk about my heart in cardiac rehab. So I have to say, shortly after I finished my cardiology fellowship in the late 1990s, Dr. Fuster actually started the first cardiac rehab program here at Mount Sinai. As most of you might know, he's an avid athlete and bicyclist, and he actually bikes the Tour de France pathway every year, every summer, not with the other teams riding, but he is a very big proponent of cardiac rehab. Okay. So first we want to talk about why. What are the physiologic effects of exercise, right? That's one of the golden rules when you're trying to take care of your heart: healthy diet, good sleep, and exercise. So really what we're looking at is the arterial function improves with exercise. It increases nitric oxide. Also affects the autonomic balance. So those people who have very high blood pressures or very low heart rates that can't change their autonomic tone, you have decreased sympathetic tone to the heart and increased vagal tone to the heart. There's vascular remodeling that occurs, and angiogenesis, which is a big thing they see in the cath lab. So if someone comes in and they've had a chronic occlusion over years and years, when they inject the dye, they often see these minor, smaller blood vessels, the coronary circulation collaterals. So, it's something that the exercise helps induce. And then we have cardiac preconditioning. So increase again in nitric oxide, increase in calcium and mitochondrial function is all very healthy. So as Beth mentioned, we have our new area, which is in the KCC building, the basement level. It's 1450 Madison Avenue. It's a beautiful, large area with great exercise physiologists. We have Craig Feynman, who is our Director of Clinical Operations. He's a physical therapist by training and worked for many, many years on the cardiac floors doing physical therapy in cardiac phase 1 in the hospital when people are post-operatively. And this is a great amount of exercise equipment to choose from. So, and I'm going to do a quick overview of what really is the description of cardiac rehab. It's a comprehensive, medically supervised disease prevention program. I also give the analogy, like if you have a patient or yourself that has a knee injury or knee surgery or hip surgery, and someone said, okay, sir, you should, or ma'am, you should go to physical therapy, who would say no thank you, right? Physical therapy is done for anyone who has an injury. So think about the heart the same way. You have a MI, you have bypass surgery, you have an injured heart, you need to go to exercise physical therapy. So typically it's 36 sessions, 31 minutes per session, lasting around 12 weeks. We've seen that it reduces mortality rates, reduces morbidity rates, decreases hospitalizations, and improves quality of life, right? So who would say no to those benefits? Typically, it's in an outpatient hospital setting like ours, related to the hospital, but outpatient. It's staffed by clinicians, exercise physiologists, nurses. We integrate with pharmacists, and we have a nutritionist on staff. We also have the ability to refer people to psychosocial help. The barriers are that some people just don't know about it, or they think, oh, I don't need it. I can just go ahead and take my medications. So it's been shown that if the medical practitioner, the nurse practitioners, the nurses, the MDs in the hospital recommend cardiac rehab, then they're much more likely, if they strongly recommend it, they're much more likely to participate. This is a great slide about saving lives. You think about all the other medications and treatments we give for our patients to save their lives: the antiplatelets, the ACE inhibitors, the statins, the beta blockers, and then cardiac rehab. And actually, per dosing, cardiac rehab saves more lives than any of those medications. So lives saved per 1,000 patients. Again, I just mentioned about decrease in mortality, decrease in readmissions, which is also very important. So we have patient assessment is the first thing that happens. Exercise training. Some people come in and they're very athletic and they already run marathons, but they still have heart disease, and others have never been in a gym in their life. And then we have weight management discussions for everyone, and psychosocial management and referral for further help for those who are suffering from depression, which is a common comorbidity with cardiac disease, lipid management, nutrition counseling. We have a nutritionist on staff, and we have an endocrinologist, Dr. Mechanic, who works closely with us to really talk about weight and nutrition management. So in 2025, what's happening now? So who benefits? So, everyone can benefit, as I mentioned, and where should they go? So typically we talk about being in a place like a hospital-based area, but also we can talk about delivering care at home now. And so this is the newest thing in 2025, the ability to have some virtual cardiac rehab, and partly in person and partly virtual. Some of the insurance issues are being worked out for the purely virtual ones, but those are really good opportunity for those that live far from a hospital-based program. We really need to get them involved. So when we're looking at our patient in the hospital, all of the practitioners here, who is eligible to enroll in cardiac rehab, and it's covered by insurance, so it's not out of pocket. So anyone PCI, CABG, valve surgery, STEMI, non-STEMIs, heart failure. So importantly, ejection fraction less than 35%. We actually have a special LVAD program in our cardiac rehab program. I was very nervous when we started. I have to have Jen Ullman, I hold my hand and make sure. And Craig is like, let's do it, we can do it. And I'm like, okay. What happens when the battery stops on that LVAD? Who do we call? But we all were trained, and we have a robust unit there. We also have, with Dr. Kontorovich, a dysautonomia program. So all those patients that come in with POTS, you can refer them for this dysautonomia, so we can train them. And we have heart transplant patients. So the acute contraindications are really people who are very sick. It's very obviously they have uncontrolled arrhythmias, or they have a very short life expectancy. We still will take them anyway. And importantly, what our team is very good at is really looking through the medical chart and making sure if they have some incompletely revascularized coronary disease, we have to talk about it. Let's say they had an LAD stent, but they left a 60, 70% RCA that's not done yet. We really want to make sure we talk to the interventionalists and make sure we can optimize their care before we put them in the gym. The barriers to enrollment, really some people lack the medical coverage, transportation problems, geographic barriers, people who have full-time jobs and really don't want to take time off for that, or those who are already in the subacute rehab program. So as we mentioned, the first phase is phase 1 in the hospital with physical therapy. And those goals are really to look at their response to changes in position, to get them to walking, doing their ADLs, to get them to reach around 3 to 4 METs of activity. And then once they're discharged, they're eligible for outpatient cardiac rehab. And then phase 3 is after the insurance-based phase 2 is completed after 3 months. We give them the option for a self-pay phase 3, where they can come to the gym and still exercise with us and have us available for help. But it's $150 the first session, and then $75 and $50 it goes down. But so it's a self-pay program, and our patients, most of them really, love to do that if they're not working full time. Okay, so let's see. Importantly, because we just passed our JCO directives, that we're very happy. We did very well in our evaluation with them. It's a class 1A medically recommended guideline. So, every hospital really has to have the option to have cardiac rehab. Again, we're lucky that we have monitoring during the program, and now we'll talk about in a few minutes about what are we going to do about the remote access to telemetry monitoring, which is very important. So some people who live far away cannot get to a cardiac rehab program. The outpatient home-based programs are they can go from 6 weeks to up to 6 months, depending on the rate. We do initial consultations. The home exercise programs are usually 2 to 5 times a week, 40 to 60-minute sessions. It's like going to a personal trainer, to be honest, right? But it's really for your overall health. And so there was a recent look at of 1,588 studies, 14 randomized clinical trials involving almost 3,000 people included in this review, showed that when compared to usual care, the participation in the home-based cardiac rehab showed significant improvement in mobility. Functional capacity improved, step counts, exercise, depression scores. It's also a very important variable that we didn't talk to as much, but we've definitely noted that. and effect on medication adherence. Because every day that patients come in, we have our nurse and talking about, did you take your medications? Why is your blood pressure high? Why is your sugar high today? Why are we taking you to the ER for those things, which we've done in the last couple of months? Severe hypertension, they didn't take their meds, high glucose, et cetera. So we retrain these patients. So now, the future. What's going on with technology and AI, right? So I know that's one of the themes. And so, here, when you look in the left corner, exercise and physical guidance, right? So we're in the gym. If we're doing it remotely, right, we can have cameras and monitors, home-based watches or telemetry monitors. So we can monitor their heart rate remotely. Same thing with nutritional counseling. We can do virtual visits. Stress reduction, similarly, instead of having one-on-one talking sometimes, which you can do that also virtually, is to do things like music therapy, dance therapy, suggestions, risk factor modification. In person, we look at their weight, we look at their waist circumference, et cetera, and then we can talk about ways to treat it. Medication management, either personally we look at their list in front of us, or they send a screenshot over the audio or over the visual monitor to show us what their regular medications are and any problems. And so there are three ways to talk about virtual or hybridized virtual capability. So we have the hybrid models, which right now insurance is covering some of that, where sometimes they start as an in-person and then they go to virtual. And so therefore we have the flexibility of knowing the patient before they can do the telehealth or internet-based programs. We've been negotiating with a couple of companies about which one to choose to go forward with making this a full-time, ability in our program. And then the wearable technology, most of us have seen the Zeo patches that we put on patients for monitors. At home, they click a button if they have an event, and we can figure out what their arrhythmia is like. And then we have everyone who has their Apple Watch and their sensors or rings. We can use that, and we can have Craig over here, be following the patient over here who's hooked up. This is really part of our gym, but we're going to pretend she's at home and hooked up to monitors. So we can have the dual AVI interface and both synchronous and asynchronous sessions. It's the one thing, like right now, from a financial perspective and insurance perspective, they want the synchronous more likely so that you can watch them live, as opposed to having a tape of them that they did at 10 o'clock at night and doing it asynchronously. For now, we're still recommending the synchronous. And then these are the technologies that are in place for the programs that have started. We haven't started officially yet. Like I said, we're still negotiating which program we're going to go with. And this is a Zeo device that we see in our clinics. And then finally, then we can do something like this, even just with iPhone, the patients at home, and we can see at least how they look, and they can report their blood pressures and their heart rates and on their watches, et cetera, so we can have an idea of what's going on. From a Medicare perspective, they still want this synchronous, they're reimbursing the synchronous remote cardiac rehab, not the asynchronous for now, from a billing perspective. Finally, we'll talk for 1 minute about AI and where we're going with that. I really love hearing Sophia's voice, with Dr. Kinney this morning, and what the AI can do in cardiac rehab. The AI algorithms can be trained to analyze the patient data live as it's coming in, their heart rate variability and their activity patterns, and then they'll help to guide us, individualize the patient's needs or tailor their approach, right? And then there's the totally remote care, right? So we talked about that, improving access to care by using the wearable devices and taking those patients who say they can't travel, it's too far, but doing it from home. And then we have the AI-driven chatbots who can talk, as Sophia does in cardiac catheterization lab, to the patients to communicate about how they're doing. So we're going to optimize the transition from inpatient to outpatient. Okay, so how do you, we have 3 takeaway points. always remember, and when you're talking to your patients, right, that's what makes the difference. If it's just written as an order when on discharge and the pamphlet is put in the back of the discharge pamphlets, they're really less likely to take it seriously. So by talking to the patients. Importantly, we also have automated the discharge orders so that it's easier for all. We've given grand rounds and internal medicine fellows and the faculty practices over there so that they know how to do it, to make it more of an automated discharge. I wanted to go back one more slide, Beth. Let's see. Oh, no. Okay, it's just. Okay, you can tell that I'm, here we go. Here we go. Okay. Remember, you can tell the patients it decreases their cause of death, decreases mortality by 13%, decreases their cardiovascular mortality by 25%, and it reduces their chance of rehospitalizations and definitely improves quality of life. As most people who exercise regularly know that there's like an endorphin response to exercise. It makes people feel better. Their mood will be greater. And then these advances in technology, both with the wearable devices and with AI together, can allow for a more hybrid approach to cardiac rehab, and we can extend the numbers to so many more people. So thank you for your attention, and just remember to think about cardiac rehab.